Good morning everyone. Myself Dr. Geetanjli Chawla, Assistant Professor from the Faculty of Physiotherapy, RPIIT Campus, Karnal. Welcome to our YouTube channel, that is RPIIT Academics. Do not forget to like and share the video if you like the content, and do not forget to subscribe our channel and hit the bell icon for the early notifications also. So today we are going to learn about the subdural hemorrhage. In previous videos we have talked about the extradural hemorrhage and the difference between the extradural and subdural hemorrhage. Today we are going to learn also about the subdural hemorrhage. Where does it take place? So the site for the subdural hemorrhage is between the dura mater and the arachnoid mater. We have talked about that the brain is covered with the three layers. So dura was the first one, arachnoid is the second one. So subdural hemorrhage takes place between the dura mater and arachnoid mater. The dura remains connected with the skull. Here you can see the dura mater and the subdural hematoma and the compressed brain tissue obviously. So the source of bleed is the bridging plexus vein. The venous hemorrhage, venous injury generally takes place in subdural hemorrhage. The presentation is the impaired consciousness at time of injury and later may worsen due to the enlargement of the hematoma. Means the patient will lose his consciousness with the time. That means patient will remain unconscious, may remain unconscious for the longer period of time, and his or her condition will be getting worse day by day because the hematoma may keeps on enlarging day by day. And we have already talked about the lucid interval in the extradural hemorrhage. That will not take place in subdural. That is a whole soul characteristic of the extradural hemorrhage. And if we talk about the CT scan, it will look like a concavo-convex hyperdense lesion. You can see in the diagram also. The extradural hemorrhage was of biconvex shaped, of lens shaped, and the subdural hemorrhage is of the concavo-convex shape. Treatment generally remains the same for both. As the surgical evacuation, it can be done through the burr hole surgery, but it is a treatment of choice. What the surgeon is the main specialist of. That's why on that thing it depends the most. But yes, surgical evacuation is the main treatment for any type of hematoma. And mortality rate in this hematoma is much greater than the extradural hemorrhage because that is a thing which comes into the notice very fast, but subdural hematoma may not get into the notice fastly, therefore it may get worsen with the time. If we can also classify the subdural hematoma in the acute, subacute and chronic stage. Acute is the time where the patient has got it. If he has came to us before the 3 days, then it will be considered as acute subdural hematoma. If he has taken approximately 21 days, then it will be known as subacute hematoma. And if he is coming to us after more than 21 days, then only it will be known as chronic subdural hematoma. Yes, that much time patients take to come to us. So chronic subdural hematoma is the hemorrhage of 2 to 3 weeks old. Any patient with head injury comes to you with symptoms 3 weeks later, also suspect chronic subdural हेमरेज. मीन्स पेशेंट बार बार कंप्लेंट कर रहा है कि मुझे हेडेक है पिछले 3-4 हफ्तों से, तो देर नहीं करनी है. सबड्यूरल हेमाटोमा उसको हो सकता है, क्रॉनिक सबड्यूरल हेमरेज ये अपने माइंड में रखना ही रखना है. एंड मोस्ट कैन बी ट्रीटेड बाय burhole evacuation. The only treatment is the burhole evacuation, not the only but the useful. For non-responsive cases, craniotomy should be done. If we have done the burr surgery and the patient is not responding to us the way we wanted, the way we were expecting the things, so if he is not responding to that point, then obviously we have to go to the much higher surgeries, and it will include the craniotomies. Thank you.